All right, since you are, hi Sally, thanks for joining us. Andrew, I know you have flight waiting for you, so let's have you present first.
Just I don't know why my camera is not working. I'm just gonna share my PPT.
Yeah.
So today's topic is about double lung transplant. I'm gonna introduce where were we, where are we, and where we will be. And most
Mhm.
important of all, why are we doing this?
Mhm.
This is presented to you by Andrew Yang, former member of Chae Lab. So the reason why we are doing this is examine the current practices and survival outcomes for DLT for lung cancer patients, and to better understand future role of double lung transplant for lung-limited cancers, and additionally to understand the potential impact of immunosuppression and lung cancer progression. So table of contents will be, I'll start from consensus document from ISHLT. So this is a consensus article, conventional knowledge among physicians before the Albert Curie case report. And after that, I will present Albert Curie case review and the current and future role of double lung transplant for bilateral lung cancer. This article contains past, present, future about lung transplant. Then fourth, survival outcomes after double lung transplantation for refractory lung limited cancers. So this article deals about present, how we are how we are using BLT in cancer patients. So this article deals about present and future. And lastly, a comprehensive landscape of de novo malignancy after BLT. This article mainly deals about our future, where we should head. So, and finally, I'm going to introduce about dream study. So consensus document of lung transplant candidates by ISHLT. This was the, uh, you know, before last year, this was the consensus among physicians of how we should lung transplant candidates. So lung is really scarce resource. We've heard about liver transplant and kidney transplants commonly, but we've never actually heard about lung transplant that often. That's because lung is really scarce organ, and lung it is not only to harvest lungs. It is it is it is hard to deliver lung to a certain transplant center, and it's hard to put the lung in the patient. So this makes it really limited social resource. And by this really limited resource, it always comes with not only medical choice, it also comes with ethical choice. So ethical choice, and so in ter- so when people argue that who we should give this lung to. So there can be 30-year-old cystic fibrosis young patient, there may be a 60-year-old cancer patient. So most people will probably think, why don't we give this lung to a 30-year-old cystic fibrosis young patient? If we give it to 60-year-old patients, let's say that people live up to 100 years these days. Well, 60-year-old cancer patient can only use lung for 40 years, and there is a higher chance of developing cancer since he was a cancer patient. So let's give it to 30-year-old cystic fibrosis patient. And that was people can argue that way. And also, and that one has to so that argument has to deal with principle called utility. And there's another ethical dilemma regarding this is that we cannot devalue 60-year-old patients willing to live more than 30-year-old patients willing to live. They are both decent human beings. So there are many ethical dilemmas regarding this, who we should give lung to. So that's why candidates should be carefully selected. And after we give the lung to the patient, we have to watch out for post-transplant malignancy. So so this article says that there is an absolute contraindication as number two in absolute contraindication is malignancy with high risk of recurrence. So because of this, it was hard for lung cancer patients to get a lung transplant. After that, we had an Albert Curie case. So Albert Curie suffered from invasive mucinous carcinoma of the lung, which is a unique type of cancer. So there's going to be two treatment options for this patient. There we can do surgical resection and we can do lung transplant. But Albert Curie suffered from diffuse lung involvement. I'm gonna move my slide a little bit to show you the diffuse X-ray. So if you look at Albert Curie's X-ray, if you look at the most left lower bottom, he has a diffuse lung mucinous adenocarcinoma. So if you do the lobectomy or resection of the left lung, we still have something in the right lung. So we we even if so if we cut out that left right lung, he's gonna suffer from dyspnea and he's gonna require oxygen tank for the rest of his life. So in patients like that, we can consider lung transplantation for treatment. So we can only consider this for bilateral mucinous adenocarcinoma limited to lung without nodal involvement. So our patient was a 53-year-old man with no history of smoking, multifocal consolidations in the bilateral lung, and diagnosis was invasive mucinous adenocarcinoma, diffuse lung involvement. So over a year, he went through 13 cycles of various therapies and without treatment response. After that, he was deemed to be a potential candidate for bilateral big lung transplantation. After 4 months in immunotherapy, he suffered from pneumothorax, pneumonia with sepsis, and he was deteriorated and moved to ICU. So by moving to ICU, he had a higher ranking in the lung transplant candidates list. And after that, lung transplant was performed. After the transplantation, he was discharged and regained physical health. So this is he is CT and X-ray before 1 month. There is a diffuse lung adenocarcinoma all over the lung, which is limited lung and no nodal involvement. After transplantation, he had a clear lung, clear and healthy lung. So right now, at this point, he was 26 months post-transplantation. After that, in the in eight, 2020, April 2023, he had a left upper lobe nodule, which increased in size, and the biopsy confirmed the mucinous adenocarcinoma. It's currently status post SBRT. So there is a need to investigate and gather more data to assess the further outcome. So, current and future role of the DLT for bilateral lung cancer. This article deals about past, present, future. Lung transplant is these days. Lung transplant is commonly treatment indication for end-stage lung disease like COPD or cystic fibrosis. And lung cancer is merely 0.1% of indications for the last 20 years. The reason is because there is a five-fold higher risk of developing lung malignancies after transplantation and 15-point elevated risk of cancer development in the native lung after SLT. So this makes physicians quite reluctant to utilize lung transplantation for lung cancer patients. And there is no prospective study that compares survival outcomes between oncologic transplants and oncologic treatments and transplantation.
Go
This
back.
article,
You
yep.
go back. 13-fold elevated. There's 13-fold elevated risk of cancer development in the native lung after single lung transplant. Compared to what?
Uh, uh, I'll add, I'll add the, just a
So
sec.
you have to find the reference. Where did this number come from? What was the study? And what did they compare? Okay.
Yep.
My guess is it's single lung transplant in native lung, but what is your control? Versus who did not have single lung transplant? And I'm suppose this single lung transplant was done for non-cancer indication. And then what are you comparing to? That's my question. And then fivefold increase in the risk of developing lung cancer post-transplant compared to general population. General population meaning, and is this single lung or is this double lung? And was it transplant done for cancer indication or was it done for non-cancer indication? And why are you comparing to general population? What is the
Sure.
control treatment? So you have to give us the context, okay? Not just cite
Yeah.
whatever the author of the review paper wrote, okay?
Yes. Is it okay if I continue?
Yeah, go ahead.
Yep. So this article, just like I said in the first place, is to elucidate the role of DLT in lung cancer patients by examining current practices and survival outcomes. And furthermore, explore future role of DLT for lung cancer patients and highlight the importance of candidate selection for the DLT. So we've gone to, well, so this article has gone through articles from 1997, the one in the red box at the left at the middle bottom, and to the Professor Ankit's article done in 2021. So this is the summary of published past articles. As you can see, there were many articles, but we don't have a sufficient number of patients. That's why overall survival is kind of a is not like it's different all over the articles.
Hey, let's
And
try one. 0%, 60%, 50%, 0% recurrence-free survival, 65 months, 10 to 50, 9, 16, 9 to 76. So a ballpark range, maybe half recurred, and then time to recurrence could be about a year. And the overall survival, 5-year survival rate really varies, but seems to be maybe a little bit over 50%. But this is overall. They could be, dying from car accident. So if it's just cancer-specific survival, then you're talking about what's better survival here? Okay.
yep, I'll move on.
Mhm.
So since there are not many past articles, we earlier this year we gathered UNOS data and ISHLT data. We compared the overall survival between DLT for non-cancer disease and DLT for lung cancer. So non-cancer disease means just like I said in the first place, people like COPD and 5-year survival and 10-year survival compared was 50 to 27 and for lung cancer was 57 to 25. And DLT for non-lung cancer at ISLGT showed similar data, 50-year and 35.3, and DLT for lung cancer showed 39 to 31. So this is we can say that well, this is not like there's a like tenfold increase in risk, but this is reasonable outcome.
Well, go back.
So
So UNO states 5-year OS 50 versus 57, 10-year 27 versus 25. To me, there's no difference.
uh,
ISA HLT data 5-year overall survival 50, OS 39, 10-year 35 versus 31. To me, there's no big difference. But I don't know who's comparing what, in the quotation you had. So go on.
Yep.
So this
So
data is generated by Dr. Jian, correct?
yeah, that's correct.
Yeah. Okay.
So yep. So DLT has the potential for treatment options for bilateral lung cancer, and lung cancer who received lung transplantation showed acceptable survival outcomes. And recent advances in surgical and medical technologies increased success rate.
So bilateral, go back. Number one, bilateral lung cancer refractory. What does that mean?
Uh, uh, Bilateral lung cancer refractory to
Standard of care medical treatment options. Okay.
yeah.
Yeah. I think when you were copying pasting, you you forgot to add the other parts.
Sorry, sir. I'll edit it and post it at the lab meeting chat room later. Can I
Okay.
move on?
So go back. Number three, increase the success rate of the lung transplant. Do you have the data to say it has increased? What is the number transition? What to what? Or is it just your speculation?
It was not my speculation. There was a reference. I'll add the reference here.
But add the actual number. What study, what rate, in what time frame, with
Yep.
what um increase by what percentage, okay?
Yep.
Okay. Okay, go ahead.
So limitations for this article, we still do not have histologic characteristics and status of lung cancer patients. So as indication for DLT has been restrictive, and this could be addressed by identifying a special protocol.
What do you mean identifying its protocol? What does that?
By by uh, since we're after study, we can gather histologic characteristics and status of lung cancer patients thoroughly so that we can do further research in this area.
I don't know what that means.
Ah, yeah.
So when you say something, you have to have a clear, concrete idea of what you're saying.
Yep.
What I'm saying is Dr. Jian tried her best to extract that data. What is the histology, right?
Yep.
And probably got bronchoalveolar carcinoma. She got all that, but she wanted more concrete histology. Um, and what do you mean by the status of lung cancer? Are you talking about staging or I don't know what status means. Um, so when you use word uh terminology, you have to have a clear understanding of what you're saying. So sometimes if the data is collected in certain way, there's no way for you to go back and ask them. Because it's been 10 years, 20 years. If you email them, they don't have the data. It's the person in charge does not remember. So it's hard to go back to each institution and ask those data because it's a national international database. Whatever collected is usually final, so you can't get more data.
Yep.
That's why I said, what do you mean by identifying a special protocol? Um, okay, so if you don't understand, ask Dr. Chiang. What do you mean by special? What's special about the protocol, and what is protocol? You know what I mean? Don't just copy paste and read what it said. If you don't really understand it. Okay, next.
This is second article, Survival Outcomes After DLT for Refractory Lung-Limited Cancers and Incidence of Post-Transplant Lung Cancer. This article deals about how we are doing DLT in the present and how we should do in the future. So ISLHT report says the most common indication of lung transplant is COPD right now, and DLT is almost second times more frequent than single lung transplant. Well, although not widely available, lung transplant may be one of the remaining options for refractory lung cancer. And major concern regarding lung transplantation in patients with lung cancer is the heightened risk of cancer recurrence after immunosuppressive treatment. So it's a common knowledge among physicians that if you do a organ transplant, you have to suppress the immune system, in which if you suppress it, you you forbid it from removing cancers from body. So that's why cancer grows well after immunosuppressive therapy, and that came as a problem after doing DLT in cancer patients. So outcomes of tumor recurrence after the DLT in pooled cases series and OPTN data show that after after years, the recurrence rate elevated and recurrence-free survival, both of them dropped after years. Overall cancer specific.
So K series is I would say there's a lot of publication bias. But it is what we have, and you can see that the recurrence rate at 5, so first of all, it's not percentage, it's 20 cases, and you're seeing eventually at the 10-year mark, 9 patient recurred. 10-year mark, OPTN data, 5 out of 15. So remember, this is not percentage. This is the right y-axis is the actual number of patient. But the graph B is the recurrence-free survival. So you would see that there's more recurrence happening. Well, I guess the faster the recurrence happens faster in the OPTN group. Yeah, but it looks like the median, let's say median recurrence-free survival at the 50% is about 2 to 4 years, through or 3 year, 2 to 4 years range that you would see recurrence, like the median. Okay, next.
So this one is overall survival, overall cancer specific survival, and from pooled cases series and OPTN registry. Both of them show that cancer specific survival is higher than overall survival. So comparison of overall survival in both cases.
Can you go back? So the clinically meaningful, no, next. Clinically meaningful number is usually the median. What is the median cancer-specific survival? It's about 3.5 for the case series, and it's for the registry, it's about 3 point something. So so that number, like if you get lung transplant, median, like how long do they live with new lung? We think Albert Curie would live forever until 90s with the lung, but in fact, most people, the data says they live with that lung about 3.5 years. Albert Curie is like 2.2 years out from lung transplant. I think he can live 10 years. Look, if you look at the survival curve, there's people live out 6 years, 7 years. Okay, Albert Curie can be that person. But it's all probability. Okay, yeah. Next.
This is the comparison of overall survival between patients who received DLT for lung cancer and overall survival of patients who received lung cancer. Oh, it is in the A, and B is who received DLT for lung cancer for non-cancerous lung diseases.
Go back, go back. So it's pooled case, but I believe all the pooled cases are not reported in the registry data. That's the oh, by the way, OPTN is purely US. Is that US registry?
I am
Can you look that?
currently not sure.
Yeah. Just want to make sure it's not international. You don't have to look that up now. Just look it up, in your free time.
Yep.
So here, the pool data, the point is, I'm thinking that 20 and 15, there's gonna be some overlap because some cases have been reported in the registry. So these are not mutually exclusive. But anyway, you see that pooled cases, their performance is pretty similar. In the registry, it's only 15 cases, hard to tell, but there's the non-lung people seem to do little better. Okay, next.
So this is an instance of post-transplant lung cancer and overall survival of who received DLT from OPTN data. As you can see, as year passes, cumulative incidence of post-transplant lung cancer increases, and those who had lung cancer post-transplant had a low overall survival.
So A is patient who got double lung for non-lung cancer indication, COPD. And if they get lung transplant, do they get lung cancer after transplant? So this is a serious issue. And here is the incidence, the number of patient, and the percentage. So first 2 years, 38%. And then the fourth year is 15%. So it goes up. So 220 cases. But I guess out of how many is the key. So I think out of two, if you look at the graph B, no malignancy post-transplant was 29,000, right? So the total patient number is 320 patients. So out of that number, 220 was the incidence of cancer. And then the B is okay, they can develop lung cancer, but if they can be cured by surgery, it's not gonna impact their overall survival. So that's why if you look at B, lung cancer group did slightly worse in terms of survival. Okay, okay.
So this is the comparison between case series and OPTN data. So there were 20 cases and 15, 20, 20 cases and 15 cases each in OPTN data.
Go back. So recurrence and death. Why is it only the first row? Is it hazard ratio or what is that? P-value. Oh, it's just the p-value of maybe chi-square or Fisher exact test. Maybe that's what that p-value is, bro. So when you say p-value, p-value from what test? You have to say that in the footnote of the table, okay?
Yep. So, like, this is also same comparison of survivals, case series and BTN data. We can see it overall survival and cancer specific survivals in both datas.
So look at the numbers. So overall recurrence rate at reported point. 45, 30. Overall survival rate at report. So reported points are all different by the paper. So that's why we couldn't. This is less than ideal, but it is what it is. And we put the median here, cancer specific survival. So like I said, 3 to 4 years is a good decent understanding. The recurrence free is about a year or two they recur. Okay, next.
So this one is clinical characteristics of patients who receive DLT for non-cancerous disease from OPTN registry. Those who had lung cancer post-transplant and no malignancy post-transplant.
Hmm. So what is their difference? How are they different? So can you, so what is 198? I thought that was percentage. Is that a typo? Age at transplantation. If you look at the right column, 198.
Yeah, 198.1. Uh,
I think it has to be percentage. If you add those two, it has to be 100%. So I think there's some typo here. So see if that's a typo or if that's an error made inside the manuscript, then tell Dr. Chion to fix it. Okay.
yep.
So don't just copy paste. Think when you copy paste, okay?
Yes, sir. Can I move on?
Um,
Yep.
well, so what is the difference here? So if you look, lung cancer post-transplant people, you look at the 5-year survival rate, 47 versus no cancer post-transplant live 35. So they live longer. It seems to be opposite of the graph you showed me. Do you agree?
Yeah.
So where's the error then? can you show me the PDF file of the actual paper with table 3?
Yep. Just
Yeah.
a second.
What time do you have to uh get on the flight?
10:30, I have enough time.
Oh, okay. Are you in the airport?
Yeah.
Where did you find this quiet place?
Uh, next to Dunkin' Donuts.
Wow, nice. Okay. Let's take 5-minute break, okay? Take a 5-minute break. All right, I am back. So I don't know if you guys remember, uh, Liam, you probably remember our DART patient, Miss Bimla Kumar, Bimlar. She was in our um the picture for the pacemaker, and she was the longest surviving DART patient. Uh, and she died yesterday of sepsis. Yeah. Yeah, I was just talking to my nurse about her. But it's unfortunate. Okay. Yeah, I think she was with us for 4 or 5 years easily, and Nivo EP really worked for her. Uh, she died in ICU last night. All right, this is part of being oncologist, guys. It's just hard to say goodbye. And I was gonna call his son today. Um, share the grief. Yeah. Okay. All right, Andrew, you can resume.
So this is the table 3, PPT 5, C.
So lung cancer post-transplant patients have longer median survival and better 3 and 5 year. No, no, not better. We'll say 3 year was better. Wait, 5 years better as well. So go back to that figure in the paper. Yeah, this one. If you look here, look at the 5 year, draw a line here at the 5 year mark. The blue line is about 60%, and the purple line is about 40 something, right? Can you go back to the table? So there's something that I might, is it the same graph, or is it something looking at something different? This is double lung, non-cancerous disease, and
It's
lung
the
cancer
second.
happening post-transplant. And go to the figure 4, comparison of OS between patients with and without
Oh,
post-transplant lung cancer after double lung for non-cancer. So to me, they are same. Do you agree? So maybe Andrew ask Dr. Chian.
yep.
I think that table and the graph are showing the same thing, but I feel like there's discrepancy here. I
All
feel
good. I'll do it.
can't hear you.
I'll tell Dr. Jin about you mentioning this one.
Do you agree that they are the same thing?
Mm, yeah, I'm not quite sure.
Okay, proceed then. Go back to your slide. You should finish your presentation.
So, in conclusion, cancer-specific survival of the patients who received DLT was similar to that patients with de novo lung cancer, and cancer-specific survival was higher than overall survival in both data sets. And based on the survival outcomes, receiving DLT could be one of the treatment options for lung-limited cancer. This is our last article. It is a comprehensive landscape of de novo malignancy after DLT. This article deals about future direction, where we should go, how we should treat patients after treat lung cancer patients after DLT. So this one is an integrated review of post-transplant malignancy after lung transplant is was lacking. So that's why we published this article. This article deals about instance types, impact on survival, annual and cumulative risks on each malignancy. And PTM remains the leading cause of mortality in thoracic transplantation patients. So this is we received data and we analyzed it and we think we categorized cancer into 27 different types of cancers. And most top four of them was skin cancer, squamous cell, skin cancer, basal cell, lymphoma, and lung cancer. So we further analyzed it, and this is exact table of the this is no. This is the recipients. This is a comparison of between recipients without PTM and with PTM. So this one we we selected patients with top four cancers: skin cancer, squamous cell, basal cell lymphoma, and lung cancer, and we analyzed them over a time period. And we can see that as time passes, there is a higher risk of skin cancers.
Can you go back? So this is really interesting that skin squamous cell is by far the most common. And a lot of times they are widespread. So you cannot use PD-1 inhibitor or CTLA-4 inhibitor to treat them. So people are using different things like oncolytic viruses to kill cancer. But anyway, this is a big public health problem that transplant people get a lot of skin cancer. And lung cancer is not the most common. So yeah, next.
So among the age groups, we can see that the patients 19-year-old to 29, we can see that colorectal cancer was most common. As people get older, we get a higher chance of squamous cell skin cancer. So we divided age groups and male, female for different types of cancers. This is the table. While we were analyzing, while I was doing analyzing with Dr. Jian, we figured out that some patients suffer not only from one malignancy, they suffer from several malignancy. And there were maximum 4 malignancies in one patient. So we we divided patients into every categories, and we this is the table for the patients who suffer from several malignancies.
Go back.
So
Yeah. So, if you look at the number, fourth is only 19, third is 160. And this is mm, what's the denominator? Where is it? Can you show me the denominator?
so denominator was in well like in let's say first malignancy squamous cell origin denominator is 4,403. So we divided 495 into 4,403, and
And
this is a percentage of that.
my question is, out of how many did this cancer occur? So what's the overall population?
Ah,
Can you go back?
um,
Go back. Here, so there's male, female. So total recipients. Okay, male, female. So about 23 or 24,000, right? So out of 24,000. Okay, 24,000 is our denominator.
yeah.
And 1,000, yeah, 24,000 or 4,000. Well, first malignancy. Okay.
So we divided patients, recipients with PTM and without PTM. This was the overall survival. And surprisingly, patients with post-transplant malignancy had higher overall survival. And I'm going to explain this later. This is an odd phenomenon. And figure graph B shows top five cancer types of overall survival. And we can see that those who suffer from lung cancer have the lowest overall survival.
Lung cancer, colorectal, skin cancer, lymphoma. So what's interesting here uh, is people who get double lung and develop cancer after malignancy, it seems that they live longer. Okay. And
There is a yeah. Oh yeah.
that's very interesting. And why is that? What is the what's the immunological basis for that? So that leads to Dr. Hesong's project on this. Now, if you break down to different cancer, because basal cell skin cancer is pretty large portion, you have the graph looks very similar. But if you have squamous cell, the graph actually looks similar as the recipient without PTM on the left side. If you get lung cancer, you actually do worse. If you get lymphoma, you do better. So getting cancer doesn't mean you're going to get killed. A lot of cancer can be treated and they can still live long time. So It just gives us a lot of different thoughts. But here, what I'm a little bit surprised is here basal cell origin is a lot more than squamous. Can you go back to the very first frequency by histology and show me yeah, show me squamous versus basal. Here, it's much more squamous than basal here, right? 48%, 17, right? And then can you go to next? Next. Squamous and basal. Next. Go back. So you see squamous and basal. Yeah, next. Here, squamous, basal. Next. And here, suddenly, basal takes over. This is de novo uh, post-transplant malignancy, depending on the order of occurrence. So first malignancy, it looks like a basal is, I don't know. I'm just worried that there may have been a switch in order. Uh, so maybe Andrew, you can ask this to Dr. Jian. Can you explain the discrepancy?
So, no, I'm gonna ask Dr. Chion about this phenomenon. Uh,
Okay.
th- yeah, can I proceed?
Yeah.
So we also compared the overall survival between the patients who had single PTM and patients who had multiple PTMs. So yeah, and you can see that those who had multiple PTMs had the higher overall survival, which is also kind of a strange. And graph B show and we compared four up to four PTM having patients overall survival.
So multiple PTM that so there's what we call, maybe Sally knows because she finished MPH. It's a survivor bias. If you survive long enough, uh, and then look at something, then that in itself is a bias. So if you live long enough to get second, third transplant, um, so here is PTM. So if you live long enough to get second cancer or third cancer, that means you're already there. If you select patient on that criteria, not by any baseline criteria, it's a criteria that includes outcome. So that's a survivor bias. Uh, but I mean, it doesn't mean we shouldn't present our data. That's we present it as it is. And then B, number of post-transplant malignancies by multiple. They're not that different. Yeah, go ahead.
And we checked the and we categorized the causes of death in patients who received DLT. And this one is recipients without the noble malignancy after DLT. we can see that infection is the most frequent reason. And this one is the causes death in recipients with malignancy after DLT. And we can see that, well, infection is still the most frequent reason, but we saw that there's a imminent spike in the third year of transplantation.
So it's a really big spike. In 20 years, no one died. What happened in 20 years?
Lack of data. We don't have much data on that part.
Hmm.
And we and I as of and I remember that we didn't have enough data for really like rare cancers, brain cancers, Kaposi sarcoma. We don't have much data on that one. We just have sufficient data on really, you know, frequent cancers.
Hmm. So there's a cause of death. A lot of people die 3 year, but it's not cancer, usually graft failure, infection, respiratory failure, and then skin malignancies there, renal failure. Yeah. Okay. Next.
So our conclusion is around one-fourth of recipients who received DLT experienced PTM, and highest PTM incidence was in the second year transplantation, and highest incidence was also at the 70 to 79-year-old age group. 1 in 5 recipients with PTM was diagnosed with multiple PTMs, and overall survival after DLT was better in recipients what was better than recipients with PTM at 30 or 50-year landmark time points. So I'm gonna explain this later. Landmark analysis.
Let's go to number one. Show me one-fourth that figure. Go back to your table to show me that one-fourth.
Yeah, here. So total number was 23,935, and recipients who with PTM was 5,629.
Okay, so that's about 25.
Yep.
Okay, you can proceed.
So all those findings, we were able to identify specific times at which each PTM frequency occurred. Like we can say that, colorectal cancer happens more frequently after 10 years, and we can predict specific types of PTM over time and facilitate early detection because we know what's going to come up in specific years, specific age. And we can revolutionize our approach to monitoring and managing PTMs. There is a huge limitation, just like Dr. Chae mentioned like 5 minutes ago. There is a higher chance of developing cancer over time, even though we performed landmark analysis. So I'm gonna explain this one. So I'm gonna be honest. I I haven't done MPH. I did my best to make this really easy and simple all over the weekend. I had help from Dr. Jian and Dr. Liam. I don't know if it's easy enough, so I'm gonna do an elaboration on this one. So I
Answer
sent this.
one disclaimer. You
We,
don't need MPH. Every
yeah,
MD should be able to understand epidemiological concepts because you guys take epidemiology class
yeah,
in medical school. Okay.
yeah.
So
Okay.
so it's not an excuse that you don't have MPH.
All right. I was lazy. I know. I didn't study enough. Sorry. So I'm gonna do my best to do an explanation. I This is on this article at the bottom on unjustified benefit and moral time bias in the analysis of time-dependent events. So this part of the article I wasn't able to participate in. I just by the time I leave Chicago, this was this part was starting. So this article was forwarded to me by Professor Daniel Shin. So I had this article had a quite good elaboration of what the immutable time bias is. So let's look at if you look at this graph. So this is a really easy concept. So there are two kinds of patients who had graft failure. Sorry, there's two kinds of patients who received transplantation, those with graft failure and those who had not had graft failure. If you draw their overall survival, they look quite similar. So it looks like this is a conclusion, but actually this one carries in bias. And if we extract just 5 patients from this data, we can, if we see it. So patient number one didn't suffer from graft failure. He lived to 48 months and died at 48 months. Patient number two lived longer, but he we lost follow-up. Patient three had graft failure. Patient four had a graft failure, and patient five did not have a graft failure. So by looking at this one, in order for, well, even if it's graft failure, and in our article it's post-transplant malignancy, in order for graft failure and cancer to happen, we need time. So those who live longer actually suffer from more graft failure or malignancy. And if you look at patient number 5 here, he died quite earlier than other patients who suffer from graft failure. So patient number five in our case is we if we do the analysis and we consider this patient as control group, patient with no graft failure. So if these early early dying patients stack up through the year and we have more control groups. So this is actually contributing to bias. And in order, if we want to solve this bias, we cannot solve it, but one way to solve it is what we call landmark analysis. So here we have a drawing at the 30-year-old, a 30-month period. And what we can do is that we exclude every patient who died before 30 months. So we exclude patient five, and we only do the analysis of the patients who lived longer than 30 years, which is patient one to four. So if
Andrew,
we draw the,
can you can you stop? Let me answer this call. I'll be right back, okay?
yeah,
Okay, that was a transplant team trying to reach me.
So in order to, yeah, so if we set the landmark time at 30-month period, we can exclude like patient number 5. So if we exclude them, this is overall survival graph changes. So if we set the landmark to 30 month, and we can see that after graph overall survival overall survival changes like this. If we set the landmark to 60-month period, we exclude everyone who died for 60-month period and graph changes also. We did the same process to our article, and it turned out to be like this. So in the earlier slide, I showed that recipients with PTM actually lived longer. And if we move the landmark analysis to the further time, like 20-year-old period, we can see the graph reverses. So what we think uh this is due to cancers that are not non-lethal, like skin cancers. Skin cancers. Skin cancers are non-lethal, easily detectable on the skin, and easily curable. But cancers like lung cancer, those are lethal cancers that affects more to overall survival. So that's the conclusion we kind of made back when we were writing article. This is due to cancers that are non-lethal. Non-lethal cancers, actually, there are many non-lethal cancers like skin cancers.
Can you go
So
back?
this is
So 3-year, 5-year. So at 3-year, we see still PTM people live longer, but as you go out, we kind of lose that trend. And when you go to the 10-year, it sort of reverses. Okay.
this is the exact same table for the graph.
Okay.
So yeah, last part I'm gonna introduce about dream study. So this is the exact same article, consensus document for selection of lung transplant candidates from ISHOT. So International Transplant Society forbids us from doing transplant and transplant on malignant cancer patients. So like active cancer patients, those are contraindications too, but even patients ha- who had who had cured cancer in like 5 years before, those are also considered contraindication, and those patients rank lower in the transplant list. And after we started Dream Project earlier this year, we divided 3 cohorts. So earlier this year, there was only cohort A and B. So cohort A is primary lung cancers. Those who, this is just like patient Albert Curie, who only had lung cancer, lung limited cancers. So we do a procedure double lung transplant. And cohort B is metastatic cancer to lung. So another cancer from another part of the body travel all the way to lung, and we do a double lung transplant. And cohort C is kind of an unmet need among other patients. This wasn't here earlier this year. So this happened early. This We added this cohort in this summer. So what it actually says is that patients who let's say that a 65-year-old male patient has an ILD, severe ILD, and he has a history of cancer like 5 years ago, like stage 1 and 2, and which was perfectly cured after SBRT. And what ISHLT forbids us from doing is that we cannot give lung transplant to these cured patients. And these cured patients were unable to get a transplant from other transplant centers and came to Northwestern for to get a transplant. And that's why after we created cohort C. So if you follow Dr. Chae to the Marcus Clinic or Olson Clinic, you can actually see many of these patients. So yeah, these are 3 cohorts for a dream study. And that will be over.
Okay. Yeah, nice overview. Um, um, okay. So I'll give you comments. Number one, you did go through each paper more in chronological order, the order it was published. I would, you can keep this format, but I would reformat into, you know, so when you present, you have a question. So, like you said in the beginning, why are we doing double lung transplant? And what is the survival data, recurrence data, and is compared to the non-lung indication, because that's our ultimate control. People are getting transplant for non-lung cancer indications. So compared to that group, how are they doing? And I think that's the key. And if they recur, is this treatable or do they die from it? What is the data on that? And then if they get lung cancer again, what is the chance of them getting lung cancer again? And it's that lung cancer, and this is related to Dr. Eugene O's project as well. It's a theory of contamination where you transplant lung, but your previous lung cancer still is around, lurking around in your body. So even if you transplant new lung, your old cancer comes back right away. That's what happened to Albert Curie. If you read the article deep enough, when we did the next generation sequencing, there is actually same mutation at the variant level. They are same. So the question is, when they recur, is it recurring from their old lung cancer, or is it a whole new cancer arising from immune suppression? The answer is both can happen. In most cases, the prior lung cancer recurrence happens within 6 months of the lung transplant. So what is data behind that? What is data behind? So I would say this is almost like contamination. Versus the whole new de novo lung cancer or skin cancer that happens after transplant. The second question is, okay, they happen, but can you cure them of cancer, or do they die of those cancer? So um, so imagine yourself as someone who wants to dispute this argument. Like, I think doing double lung transplant for lung cancer is unethical. Here's the reason why. So you think about people who are trying to take you down, and they say it's unethical because, well, what is the actual data? You show them the data. They say this, but then what does the data say? So rebutting all their points by only presenting the relevant and most, I guess, evidence-based data or the logic that you have. Not in the order of how the journal was written. So maybe the next thing you could do, Andrew, is to reformat this so that this could be something like a TED Talk. That this would be, so get rid of all the things that I'm not interested in, the skin cancer, which skin cancer is most common, although you have to clarify the data. This is solely about, okay, I don't believe lung transplant should be done in lung cancer patients, period. I think it's totally unethical. And that's the majority of the medical oncologists in the US. Now you have to fight that bias, okay? Then you have to go inside their brain and rebut, okay, all the points that may have in their mind and show them the exact data. And I think I did tell you to present the Dr. Tarik's data. You and get that from Dr. Liam and Tarik, my fellow. So there's a data. I know you have Albert Curie's data. He's living out like 26 months. But we have other 5 transplant patients. What are their survival? How are they doing? And then if you read close enough, why is Northwestern trying to do this? I guess the number one, it's we can't say we have to do it. Our best argument is that no one has collected data in a prospective manner. It's all registry, it's all retrospective. We're the first one to prospectively collect data and present. And the innovation is using the cardiopulmonary bypass and doing a non-sequential lung transplant. Before you would take out the lung, put a new lung, and then go to the other side, take out the lung, put the new lung. And if you do that, you'll contaminate. The cancer still is there, and then we'll go to the other lung because it's air space spread. Okay. And we believe this is the reason why Northwestern patients in particular are doing better than the literature. So add those data, and then I would suggest you reformat your presentation. You can show me on the next lab meeting what the revisions that you have made, and address some of the comments that I had for the data after discussing with Dr. Shion, okay? Do you have any questions?
I'll deal with comments. I I have no further questions yet.
Okay, okay,
Thank you for your comments and everybody else.
no problem. So this was a nice
Now I
view.
gotta go.
Oh, you gotta
Oh
go?
yeah, thank you.
All
Oh
right,
no, I got a few minutes, so
safe flight back to Korea.
thank you.
You're welcome.
Thank you everyone.
Okay, let's do Monica. Can you give us update?
I have a very short and sweet update for
Yeah.
this week because initially I wasn't well and then I had interviews, so uh, I couldn't finish much. However, I finished up with all the segmentations of tumor, peritumor, and harmonization. I will be uploading them on the drive and sharing them today and start working on the SOP. Uh, this week I have this week until I will be gone for another interview. So I plan on finishing everything and also finishing the SOP which I hopefully will be able to show you on until Friday and then leave. And then when I come back, I'll start with papers.
Okay,
That's all I have for now.
good. Um, when is your next interview?
It's actually on 21st, but because it's in person and it's in another state, I'll have to leave. I'll be leaving on Saturday.
When are you coming back?
Uh, next other week because they've put like the resident meet on 18th, and then I'll have to stay for 2 to 3 days for just there, and then I have the interview. So it's like entire week is gone.
Hmm. So you can,
Be able to work from the hotel. So
are you coming back on 26th then?
so I will be back on 22nd, but I guess it's Friday, so the next Monday I will be in the lab.
Yeah, Monday is Christmas, so 26th.
Oh,
Yeah,
I
yeah,
would be here. Yeah, I don't have any other plans for Christmas, so I'll be there.
okay. Yeah, are you able to join lab meeting on the 19th?
Yes, yes, I will be.
Okay, good. So keep writing, okay? Keep writing and yeah, we're almost there. I feel like we need to publish what we have, so keep up the good work. Uh, Seungmi, let me have your updates or whatever you did.
Yeah.
Oh yeah, it goes.
Right. So for me, I did start the EMB and I have like one question for the EMB project in data collecting. So I'll start sharing. Um, just give me 1 second. Mm, yeah, just start sharing now. I'm the first one. Huh? First, you first one? Start this and then work as usual. Oh, okay. No, this is not it though. Uh-oh. But you can change. It's like how do I change? Do you know how
You
to?
can just open up like normally.
Oh, okay. Got it. Thank you. Um, basically, it's one patient. It's her. And basically, my question is, so it looks like she was on co-center trial on Nivo EP and radiotherapy, and then now she was off it for pneumonitis, but that's things that happened in the past, like before our set before our time. This is our time frame. But what happened in the time frame was she was restarted on Ibonip and then had this and then Deponent. So which is TKI. Um so my question is that um, so sorry, I'm just gonna
What's the name of this?
it's Leah Mortensen. So
Oh, this is not my patient. This is one of the other thoracic attendings patient. Okay.
yeah, sorry, I didn't expect Monica to finish this early, so I wasn't like prepared like 100% to present my things. But
So what is your question?
yes, so if you just give me 1 minute, I think I could just figure it out. Like um sorry. So I guess my question is, we don't really, I know that with each, I would like to show you the Excel sheet, which I will have to do using the main computer. So I'll just share a screen using my main computer, and then it will make more sense. Yeah. So for her, which is patient Leah Mortensen. So if I understand correctly, every time there's a new treatment line, which is including immunotherapy,
Huh?
with or without addition of new chemo, we make a new line. That's my understanding. And the thing is, I wasn't sure what this meant, like line of therapy after new staging, and also this is within that time frame that we decided on. These are the treatments she had. And of course, this and this doesn't include immunotherapy. So should I just get rid of these lines? Because we're looking at immunotherapy. I
I
think that's the rule. Yeah. It's
mm,
it's about collecting data like correctly at the first time because this is a very vast database.
so
So and it tells us and it's here like how when they got the treatment.
I
It's
see.
yeah. And when they progressed. So
So I guess we were only recording the ones with immunotherapy, right?
yeah, I think that's my understanding. Um,
Huh. In that case, we don't need yeah, number 3 and 4.
I mean, yeah, and
So carbopem, was that added later on to Nivo EP? Can you go
yeah,
back?
because if she progressed and then she progressed at this date and then they moved on to they added the carbapenem.
How long
Um
was the patient on Nivo EP alone?
she was on it so for a long time. She was on a co-SINAR trial, which means she was on Nivo IP and
Therapy, yeah,
radiation. So if I open up her
year,
chart,
right? That's like a year. There's duration of treatments there. But you added carbopem, it looks like that also lasted like a year.
yeah, so she initially started Nivo IP in 2018.
Mhm.
And then she had pneumonitis, so she was on and off, but mostly on Nevo.
Uh-huh.
And then there was some bone lesions, which is when, so she was, yeah, she only was getting monthly and then started again.
Oh, okay, it started again. So 2000, well, complete. So the cosine 2018 to the progression happening in 2022. So that's like 4 years.
Oh,
Wow,
but she was treated through progression because she had progression of disease, but they were treating her through.
I see.
Yeah. Like yeah, it's mentioned throughout that they're treating beyond progression.
And giving SBRT. Okay. And carbopem Nivo just worked for like 6 months or something.
Yeah.
Yeah. So this is a odd situation where
Yeah, but I feel like there's are cases like it's complicated with most patients.
right,
Um, not most, but few.
yeah, okay.
Um, yep. So for her, I mean, I guess we could delete these. Like it's like later.
Right,
And
agree.
one other person that one other thing was with Guardian, and so if you look at our Guardian, like sometimes it's initially detectable, but it gets undetectable like this. Um, Meaning, and then within the time there could have been progression of disease or a change in treatment. So when I fill out these lines, so when I fill out the Excel sheet, do I try to get a Guardian, um, do I try to get some Guardian data that's around the time, or just stick with like the initial one or the one with most mutations?
Oh, so does it not, it's, does it not, well, there's a temples and gardens.
Because we're putting in I don't know, I think one study around the time they start the treatment, meaning as close as possible to the initiation of the immunotherapy, the treatment. And then yeah, that's what we're doing. So I was wondering if I need to do that for each line of therapy.
Hmm, I think that's too much work. I think it's too much work, so I would be fine with just the baseline. Even if it's second line, just the baseline, meaning a diagnosis baseline.
Right.
Um, and it looks like for TMB, Tempest Gardens. So how is BHBI different? Is it just actual value? And
Uh,
then,
uh, this one?
yeah,
Yeah, so the TMB, there's like multiple sources to get the TMB.
right.
But it seems like the cutoff here is 6.8, and it's I guess I getting the TMB wherever I could find it. It yeah, it could be from yeah, just trying to get it whenever I find it, so I'm just using this.
Okay. So my question is for the actual gene KRAS EGFR,
Right.
don't know where they are from.
Oh, where I'm getting this from.
Yeah,
Yeah,
could
so
be
it
temp,
depends.
right?
It's Guardian, also the comp Guardian, and also just NGS, and some if it's from like a different hospital, they sometimes ran it, they ran it themselves, like ALK, like if it's old data, just I think wherever I could get it on the file. Yeah.
So I'll say it's okay to use anything because the false positive is very low. So anything that's positive, I trust it, it's real. So I would use it. Uh,
Or is there
regard.
something you want to not use? Like avoid?
No, I would, but Yeah, so it doesn't matter where it's from. If it's positive, just record it. It's okay.
Yeah.
And then
My
your question is for the second line, do we have to use the, immediate prior second line treatment gardens? So the answer is ideally, but it's too much. So I'm okay with just using the same baseline gardens or Tempest or the in-house NGS.
um, um
Okay.
yeah. One other thing is it's more like just it's the way the Excel is made. So it's very cleverly made so that if I just paste, so this one I just pasted from Garden. It includes like variance of there's sometimes it includes the variance of unknown significance. And then this Excel sheet is very smart, and if it notices anything with EGFR, anything with ALK, it will just put as one.
Really?
But yeah, it's very cool. So if I just copy it this,
Uh-huh.
and if I paste it here, okay, oh maybe I'll do it here. So this one's like, if I paste it here,
Oh,
if you look at this, it's one. So I didn't make this, of course, but it's amazing. But I just realized that it's not every EGFR mutation we're interested in. I think we're interested in the ones which have targeted therapy,
yeah,
right?
right.
And so I thought, for the future people involved, not every KRAS mutation is the one we want to be seen here. But this will automatically, if they just, put it as one. So I think maybe I should just clarify which mutations are the one we're looking for, just even as a side note, like below here, just so that people don't get confused later on.
Sure, sure. Okay,
Yeah, that's about it, really.
great. Thank you. Did you
And
have a journal club?
oh, I do, but I didn't finish it this round, but I will do everything next time because I have time.
Did you say, are you available? Because
I
you
am I changed and made room for Tuesday mornings in the next 3 weeks.
awesome. So you have next week you can do, what was the topic I gave you?
It's CTLA and PDL1, like Ipi-Nivo, using
Right.
it together, what are the like side effects, what are we worried about? And then there's also a lot of smaller things that you've mentioned, which I just I'll present it like nicely.
Yeah, yeah. So that will be the next one. And the following week or the following week within that 3 weeks time frame, I think one, nice review paper would be to look at predilection for metastatic site, sarcoma lung, um, colorectal cancer to liver is a great example. So what is actually the frequency of that across all solid tumors? And by that, I think, it's good to focus on lung. What gives lung cancer only metastasis versus multiple site metastasis? And do we have any data on that? It's gonna be a really niche paper, but it will be a good paper to give rationale for our dream cohort B. Okay, so uh writing such paper and it's gonna be a lot of data pooling. So it of itself could be considered a original paper, so you could present it at national meetings. So keep thinking about that project for your the next journal club too. Okay. Okay. Anything else, me?
Oh yes, so going back to the Signatera project, uh yeah, so the thing is the reviewers gave their comments. I did think briefly about it. Let me just show
Yeah, yeah,
you
yeah. Share the
this.
comments.
Share. Let's share. Sure. Just it. Give me 1 second. Like, so this is what they are saying. And they're saying, you know, basically this is the main guy. He
Uh-huh.
said that, there is some contradiction, like primary early stage curative intent, but they noticed that there's a stage 4. How did you do this? Um, it
So
was number one.
this
Yeah.
patient is Albert Curie.
Yeah, it is. He is. Yeah. I mean, can we take him out and just change the inclusion criteria, or is it too late at this point?
I would say explain why this was curative and he's still cancer-free, doing well. Uh, and say, but that's why we think it is still a curative treatment option for him. And it was truly lung limited case.
Mhm.
Explain
Yeah.
and even put in a citation because we have a abstract for Albert Curie, right? So to put in a citation for that, and then say, however, we are also open to taking out this case if you really think there should not be any stage 4 case for this patient. That we're also open to that idea. But however, we do believe bilateral lung transplant was curative treatment option. And yeah, I think that should be enough for this review.
Okay. And then reviewer one was saying, the main limitation is absence of pre-medical treatment Signatera study, of which there's only like less than 5 patients, if I remember correctly, who had like pre-treatment Signatera, because everybody came to you like and then got the Signatera. So um usually after they progressed, they had got curative intent somewhere else. So the Signatera was mostly obtained. Not many were obtained prior to definitive treatment. So I don't think there's anything we could really do about
Yeah.
this.
So that's just comment. We don't have to respond. There's the comment.
And
So
then yeah,
yeah, may benefit from. So how many were EGFR?
I think it was only like 40-60% like ratio. So like
Yeah,
almost half, yeah.
show me the
Exact number.
yes.
Yep, it will be. There it is. So
That's a lot of patient, 15, right? That's a yeah, so I think we can separate them
Mhm.
and we report as a lump, but also we report as EGFR mutated, wild type, and separately. It's fine. Let's just do that. I think it's easy.
And then this is I think this is also one of the main limitation that we did not state like the criteria. But if I remember correctly, when I was collecting the data, um, at a certain time, the initial data we got was a very extensive list, of the patients you were seeing, and then and
No,
then
these
I think
are all the
most,
patients that I ordered Signatera. We didn't select any patients, so just say these are the patients who are on curative intent, patients seen during this time period in a consecutive manner. We didn't select them, in a consecutive manner
got it.
were included. Just say, yeah,
Um,
that's enough.
and reviewer two. So it's
Oh,
basically
yeah, yeah, and then who consented to serial blood monitoring of ctDNA. So some people would say, I don't want it. I don't want to pay for it, right? So it's the consecutive time frame and then the patient who consented. Those are the
Mhm.
criteria.
Yep. Yep. And then the reviewer two, yes, good points. So just a specific description how the study evaluates patients for radical treatment. So I think we had some definitive chemoradiation patients, and then albuquerque. So in this case, albuquerque, it's pretty, it's self-explanatory. But do I also discuss the medical, how we decide on when stage 3 patients get definitive chemoradiation? Is there something is that what he's asking for, or?
Specific description of how the study evaluates patient for radical treatment. I don't understand what they're asking.
Is it possible for me to ask them again after after I write up something, each of the points?
I mean, anything is possible, but it's gonna take the turnaround time is not
Oh,
gonna work out that way. So we just have to guess what
mm,
this reviewer wants.
got it.
How study evaluate the patient for radical treatment? Specific description of how the study evaluate patients for radical treatment. In the how the study evaluates patients. Oh, just say curative intent treatments were offered after evaluating patients for radical treatment at the multidisciplinary thoracic tumor board.
Oh, okay. That's true. Oh, that's the answer, I feel like. But at the same time, yeah, I mean, yeah, like what more is there to say?
Yeah, yeah,
Just, you know.
okay.
And then again, this is Albuquerque and has negative ctDNA for the first time. It is recommended to further discuss the reasons. Oh no, it's not Albuquerque, sorry. 23 is uh
For the
so I
first?
know who 23 is.
Hmm.
Yeah, so
Isn't that
I'm
Albuquerque?
just trying to
Four
figure
A
out.
is Albuquerque.
I'm getting confused, but sorry. recent.
Yeah, because he's the only stage 4.
Oh, you're right. You're right. Yeah, so it is Albert Curie then. Um,
So this is our speculation is that. So and then it says the first it says where is that?
it,
For the first time. I think for the first time means even before transplant. So you think, right?
um,
Is that what
so for the first time he had, so to be honest, yeah. To be honest, I don't know what he means, but um,
yeah. So I think this is so the answer is this. Okay.
mhm,
For this Albert Curie, his Signatera before transplant was negative,
mhm.
right? Do you have that figure?
Yeah. Oh,
Uh,
definitely. I checked. He's been negative before. Yep.
yeah, show me the figure. The figure, the swimmer's plot figure.
Or to see. Oh dear. It's just I have a lot of screens. The Zoom screen is making me a little confused. There it is, yeah. So it's 23, Albert Curie. So I don't remember him ever being positive. So when he said for the first time, I'm not really sure what they mean.
So 23, where is positive?
So there, though I don't remember there being a positive.
So was it 20 patient 20 what?
23, like this person.
So Albert Curie had chemoimmunotherapy, right? Yeah. And was negative, and it's always been negative. Yeah. So yeah. Okay. So this is what I think. Because Albert Curie had cancer with cancer
Mhm,
lipidic growth, adenocarcinoma with lipidic growth pattern that mainly spreads through airway
mhm,
and had no clinical evidence of distant metastasis and seems to be and likely um uh 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 and treated with double lung transplant.
mhm.
Um because of all that, we observed no detectable ctDNA in both pre and post transplant. And this is likely explained by a low shedding rate of DNA of this unique cancer. So
Oh,
yeah, that's how I explain it.
oh, because the surgery itself could sometimes make some positive. Is
So so
that
it,
what the reviewer is trying to say that it's
no,
ex
no, the
yeah.
reviewers not understanding why it wasn't positive in the first place.
Oh, I see, I
And after
see.
surgery, it becomes negative. That's what they want. But in Albert Curie, before transplant, circulating tumor DNA was still positive, negative.
Got it, got it.
They don't understand that. So just say pre transplant was negative, likely because of its unique low shedding rate seen in mainly in lung cancer, lung adenocarcinoma with lipidic growth pattern. That mainly spreads through airway.
Got it. Yeah. Um, so what I think there is less like description on like, like the pathophysiology, like biomolecular like things, but in the in the in the writing in general. So I think it's like a good addition to add that. Because anyway, and then this, yeah, so it's another case, but this case has a patient who was initially positive, then negative. Patient is Harold Daniel Del Jara, um, a patient. So if I show him who he is, and um, so it's this person, and then that's the curative. So he also progressed. Basically his cancer is he got surgery and then adjuvant chemotherapy for stage 3A cancer. And initially his Signatera after curative treatment was positive, and then it became negative. Even after progression. That's how I remember it. And if you look at the manuscript and look at the swimmer plot,
Hmm.
so if you go to the swimmer, it's the patient they're asking is 17. So or 17. Yeah, I mean sorry, 17 is here.
Hmm.
Yeah.
So what does it say? Surgery and then
Got the
pos-
cert.
positive ctDNA and then immunotherapy.
So yeah. It was in positive after surgery and then became negative. And
Hmm.
then he had, and there was like no evidence of disease. And then he recurred. So he had progressive disease, but the signatory didn't catch anything.
Hmm.
Should I delve into his chart and see if I could find any like medical, reasons?
Yeah. So if it is, I can tell you if it is CNS recurrence, usually blood DNA doesn't catch it because
Oh,
you need CSF ctDNA.
got it.
Or
Also,
so you could, yeah, find out what that recurrence was. Yeah.
but it says it was progression, right? Oh, so 4R lymph node metastasis.
Hmm.
I don't think it was CNS.
Okay. So
Yeah, yeah. I'll look into the chart just to double see if there's
yeah,
anything interesting that makes them different.
show me the comment again.
Sure. So the comment is that, oh, so, do you see it now? Yeah, this is the comment.
Further discuss the reason. Why? It is what it is, but reason? Well, you could argue. So maybe understanding what exactly was that progression will help us because, we are calling it progression, but it may not be progression. It's not biopsy proven progression. So there's a possibility
Mhm.
but so yeah, after you study the chart, let me know. We'll come up with the answer for this.
Yeah, there might be something medically that makes him different, if who knows, like and then I think based on the testing result two patient involved, does have an impact on the progression? So he's bringing up immunotherapy
Mm.
on the impact of ctDNA assessment, which is like very interesting comment
Mm-hmm.
because in our journal we didn't really discuss immunotherapy as much, other than who got what. Like, I mean, how many people got it. It was more like, curative treatment. It's the C trend. So
Does immunotherapy combination have impact on progress of CT? So it's right now, we're still at the hypothesis generating phase. We didn't so the answer is it's hard to tell only based on two cases.
mhm,
But we agree that impact of immunotherapy or immunotherapy combination on the progress of ctDNA is a worthwhile to look into versus the targeted therapy or the chemotherapy, whether type of therapy has a unique impact on the progress of ctDNA assessment. Just say we agree with the idea that therapy might have differential impact, but it remains to be seen with larger study. But these two patients case are unique and intriguing. Just say that.
yeah, yeah. I think he was trying to help us, like
Yeah,
using therapy as your excuse, or but not excuse, but like as a possible, theory
yeah, yeah,
explanation. I think there are some data with now, I know this was like already more than a year ago, but now there's more data regarding ctDNA.
yeah.
So should I just, even checkmate 816 had ctDNA part of it and stuff. So I guess maybe I could, cite something, find something and cite
No, no,
something.
no, you don't have to. You don't have to.
Oh, okay. Just
Yeah,
answer.
simple. Yeah.
Got it. Thank you, Dr. Chae. Try to get this done before I go and then show it to you.
So just two reviewers. Okay. So are they calling it major or minor review?
I I don't think that terminology was in the report, so it's just
Look at
um,
it.
I think they're suggesting a transfer.
yeah, they're just it's been like denied, and it's been denied. They suggest a transfer, and then I think the signature person, they were saying that let's try appealing, and then let's try appealing, why don't we reach out directly, blah blah blah. If not, let's try something else interesting. And this Frontiers in Oncology is not the one they suggested, like the editor suggested. The editor suggested our sister journals, which are thoracic cancer and cancer reports, open access. And the signature people were suggesting, why don't we try talking to the editor in chief, suggest send this somewhere else. And then Eugene, I think she spoke with you, and then I think you agreed with their decision. Agreed. That's what I heard.
Oh yeah, yeah. Thank you for
You agreed to talking with the editor about just trying once more.
So what did
Uh,
we get a response? We don't know yet, right?
no, we haven't actually spoken with the editor, if I'm understanding correctly. I don't think we have spoken with the editor directly. Because Eugene said she would talk to you about it, and then it would have to be preferably done on your end. But my thinking was we should at least show some effort that we try to reply to all the reviewers comments,
Okay.
and then that would make it a more appealing case. especially because the main person didn't understand the stage 4 cancer. Like, how could you do curative treatment? Like, so I thought we should just kind of explain that as well as all the other comments, and this just maybe taking it out. And then that might increase your chances of getting published in cancer. It was my own thinking.
Hmm. Okay, you can unshare.
Oh yeah, sorry. Yeah.
So these are you guys learn through the submission period. So number 1 point, if they reject, the chance of them reconsidering is super low. So maybe
Um,
not worth the effort.
mhm.
Number 2, usually when they reject, sometimes they don't give comments, but you know, many times they do, like this one. If they reject and give comment, there's really no need to respond to that because it's rejected. And they deal with so many journals. Um, I think this was a good learning exercise, but in a way, it could be a waste of time because they didn't ask for revision. They just gave us the comments. So this is good because based on the comments, we can revise our manuscript. But like such, things like EGFR, the reviewer asks that we do the separate analysis, but you're gonna get totally different reviewer if you go to a different journal. And they might be fine with EGFR. So you just spend time doing something that's not necessary. So you will only revise if the journal is willing to reconsider. Now, I think this was an exception because they had misconception about how could you give some curative treatment for stage 4 cancer. And we did explain it in
Yeah.
but obviously they didn't read it. They just looked at the figure and they're just asking those questions. So in this case, I'm not gonna call or email. I'm
Yes.
not gonna do anything. You, Eugene, and Natera people can email the editor. Hey, basically this is our rebuttal letter. And because I know you guys had major concern for the stage 4 cancer, but this is our explanation. We would ask that you strongly reconsider this paper for publication because all of your comments or concerns are addressable and maybe based on misunderstanding. Or misunderstanding or not, I wouldn't use that strong word. Maybe best based on lack of better communication or something like that.
Yeah, yeah.
Compromise. And
Yeah.
then give them like a week. And if they are willing to reconsider, fine. If they're not, I would go with the one with the highest impact factor. I don't know the future in oncology has a higher impact factor than thoracic cancer, but find out which one has the higher. To me, they're very similar.
Oh,
Uh,
got it.
you can either transfer to thoracic cancer or do the frontiers in oncology.
Got it.
Liam, can you find out what the impact factor is?
For frontiers of oncology.
Yeah. Frontiers in oncology, right?
Yeah, it's 4.7 to 5-ish, which is not bad.
Yeah, so why not? So
Breast cancer is around the same.
thoracic cancer is how I thought it was 3
Huh?
point something.
Hmm. 2023. It's
What is
oh,
the
it's actually it's a lower. It's like
3?
2.9 in 2023, I think.
Okay, let's go with frontiers in
No,
oncology.
3.223. Sorry, 3.223.
Okay. Yeah. So send that to the editor, that rebuttal letter.
Mhm.
Work with Natera, Eugene to send that letter ASAP based on some of the comments that I gave you today. And let's just give them a week. They don't move, they don't tell us what to do, then we are going to frontiers in oncology.
Sounds like a plan.
Okay. So next time we're gonna do this with knowing that they rejected, because that will save time because we don't have to, we're not responding to every single detail questions.
Right.
Yeah.
So
Okay, good. Yeah,
that's
you can see
that's
it's really hard to get anything published.
yeah.
This was done when you were here, right?
Yeah.
That was a year and a half ago.
Yeah. And I think we submitted in, like, August or something. Not me, but Eugene kind of submitted in August. But here we are. So I feel like yeah.
Push and yeah. Oh, yeah. So my suggestion is get this published in preprints.
Mhm.
Did you guys send it preprint?
This one?
Yeah.
No, I don't remember
So
sending it.
talk to Natera and publish in is either SSRN or there is medRxiv.
Mhm.
So that's our role. Like when you are done with any manuscript, just publish it there.
Mm.
So we kind of say it's out published, not peer reviewed, but it's published.
Yep.
So work on that
Mhm.
with Eugene, okay?
I'll talk to her today. Mhm. Yep, that's it for me, I think. That's it for me today.
Okay.
Signature.
Let's take 5 minute break and then we can go over some updates. All right.
Stuff to do.
Okay, I am back. Take care of a few issues. So Liam. Go over any updates you have.
Yeah, so just a couple of things. I was able to work with Dr. Bhumika and Dr. Eugen and submitted their final revision for their manuscript. So I
What was
think
the
it should be, oh, let me, it was about the differentiation syndrome.
Oh, okay.
So I think that should be being published. It's processing now. It should be published in the next couple of weeks.
Okay.
And then the Dart TM proposals
What journal?
have been updated and sent to. Oh, let me.
So remember we have a journal tracker, Google Doc or the Excel, just update all of that and send me the link so that I know what's submitted where, and same thing, Seungmi or Monica, if you submit anything, just keep updating Liam because he can update the tracker. Yeah.
And then the Dart TM proposals have been submitted, updated and submitted to Megan and Katrina. Megan's away on a conference, so I got an automatic response saying she'll get back on Wednesday. So
Okay.
we'll just wait for that. And then we're also waiting for the biomarker studies. It's been on hold per legal department. I've reached out to them to schedule a meeting, and we haven't heard back on a potential time yet. So we're gonna have to wait for that, wait for them to confirm their availability and get that set up. Then
But
we're gonna.
on hold, I never got that email that you mentioned last week. So I said, what,
Yeah. And so Adrian responded to that particular email, and she said Rex is going to call you and go over the specifics, and Adrian didn't give us any more details.
Okay.
Yeah, but in the meantime, we're still so we met up with the PathCore lab manager. His name's Rael, and we've did a first run through of our lab manuals, and then we've identified some details that we needed to clarify. So we're going back and forth with the companies so that we can finalize the manual, and Will's been helping with that. And now that Sally's here, we have a second meeting with Rael next Friday when Will comes back. So we'll go over everything one more time with him.
What about alcohol samples? Where is
Yeah, so I've asked him about the remainder of the samples. I have the baseline and like the first follow-up samples, but then I don't have any information on the subsequent follow-up draws. So I've asked Rael to check his inventory and let us know how much of what we have left. But the initial Excel spreadsheet I received was only for the initial 2 draws.
So I know they need less than 1 cc. So talk to Lahel about how she can just get 1 cc out and ship that to OncoHost, and all the fee and the shipping they can bill it to OncoHost.
Yeah. So we're working on that, and then we're gonna schedule the follow-up meeting with Lunit and Picture Health.
So let's call it Lunit today. Let's maybe we should just call them today.
Okay, well, yeah, we can try calling them later in the afternoon, so it's like morning time in Korea.
No, he's in New York.
Oh, is he? I
Yeah.
didn't know.
Right. So let's call him Seungmi, you have a call from 3 to 4 today, right?
Yes.
3 to 4. So let's call Lunit about 3:30 today. You can Liam, you can come to my room, we'll call together.
Okay.
Okay. Anything else?
No, I think that's it. I just have a couple of things I'll go over with you in person.
Yeah.
And then oh, just for your meetings today, you have a Merck meeting at 12, and you have a Northwestern SIV meeting with Dr. Patel, Yoti Patel.
Yeah. I don't think I have to go for that.
Okay. And then you have the DTI candidate interview at 1. That's it for today. And tomorrow you're gonna have interview from the Northwestern media team about Keith Safran.
Yeah.
And, and tomorrow morning we have a onboarding meeting with Imagine AI. So that's gonna be with me and Sally, and I think you can just join for the initial bit. And then they're gonna go tell us about how to use their software. So for that one, I think Sally and I can stay.
Okay.
Mhm. Did you need anyone to join you for that Merck meeting, or are you okay?
Um, what am I gonna do? You can, yeah. Yeah, if you can come by 12, you can join me.
Okay.
Yeah.
All right. That's it for me for now.
Okay. Then I will see you at, just come to my office. We'll go down together. Yeah.
Sounds good.
Okay. Yeah, and then Sally, I don't, if you're better, I'll see you in clinic, well, not clinic, in lab tomorrow. Hope you get better soon.
Thank you.
All right. Anybody, any questions, anything before we wrap up? Okay. Very good. Take care.
Thank you.
Bye.